Welcome back, everyone. My name is Arina Stefanova. I'm a general surgeon HB trainee in the Kent, Surrey, and Sussex Deanery. I'll be chairing the next session with Alicia Psiha, who is an HB consultant in Birmingham and the outgoing RU Group robotics lead, Andrea Shiu, who is a recently appointed HB consultant in Liverpool and the current RU Group HPB lead, and Sadav Giu, who is an emergency general surgeon in Nottingham. Our first talk is going to be given by Frances McCarron, who is from the States. She has completed an HPB fellowship at the University Hospital in Cleveland and then a dedicated robotic HPB fellowship at Atrium Health in Charlotte, North Carolina. Thank you, Frances.
Thank you. Thanks for inviting me here. So happy to be here. Thank you very much. So I will be speaking on the case for formal robotic HPB fellowships. Is it necessary? And here are my disclosures. So I gave myself some goals for this talk. First, I wanted to describe the importance of robotic training for HPB fellows. And I think we've touched on this a lot today as to why robotics is important in the HPB realm in general. But also wanted to identify some of the struggles with current fellowship training and proctoring of established surgeons. Also want to share my experience with robotics in HPB fellowship and my outcomes in my first year of practice after completing a dedicated one-year robotic HPB fellowship. And then hopefully at the end, make the case for expanding access to dedicated robotic HPB fellowships. So we've talked about this a lot today, but obviously we're all here for the same reason. We all believe that robotics provides a significant amount of benefits in HPB surgery. We know that MIS has improved benefits over open in general, pain scores, recovery time, length of stay, etc. However, we did also talk about how the learning curves for robotic HPB cases are long and quite difficult. And so robotics really does provide more of an accessible goal to perform MIS procedures, complex MIS robotic HPB surgery, such as Whipples, major hepatectomies, Klatskin's resections, etc. So over the last decade, there's been increasing utilization of robotics in liver surgery, specifically with major hepatectomies. We've seen papers that have shown improved length of stay, blood loss, less Pringle use, transfusions, and conversions with robotics over laparoscopic. We've also seen benefits for more complex cases, specifically in the realm of liver surgery. And robotics has shown that we can perform procedures with higher difficulty scores. We've also seen some oncologic benefits, especially in regard to pancreatic resections. Some studies showing that the lymph node harvest is improved over open, that the R0 resection is also improved over open, and some studies even looking at disease-free survival and local recurrence is actually improved as well with robotic versus open. So we realize and recognize that robotics is something that we need to start doing more often in HPB surgery, and fellowship training is a question that we have, and how well are we doing with that? So here's a list of the HPB fellowships worldwide, and this is changing constantly. I had to update this slide earlier today because apparently Europe has over 30 HPB fellowships itself. And so in North America, however, we have 32 HPB fellowships. And even though we've discussed how important robotics is, there's no true robotic standard for these HPB fellowships. They only require 10 MIS cases, and those can be either laparoscopic or robotic. Only 5 liver and only 5 pancreas are required. And then there are only 13 of those programs that actually advertise doing robotics for their fellows when you go to apply for them. So there have been some studies on how do the fellows feel about this and how do they feel about the robotic training. And so ever since 2015, when Rohan Jayaraja did their first study surveying North American fellows about their specific robotic training and their HPB fellowships, we've seen that the fellows are not very excited or happy about their robotic training and HPB fellowship. And then in more recent studies, we've seen that things haven't really changed as much. So a survey from 2022, which I was a part of as a fellow, 90% of the fellows agree that robotics in HPB surgery was continuing to expand. 55% felt that their training was essential for their fellowship, and 65% felt it was essential for their careers. 86% had robotics offered in their fellowship. However, 73% of them had no formal robotic curriculum, and they were only slightly satisfied with the amount of autonomy that they were gaining, and most felt that only a quarter of their case volume was robotic. And more importantly, at the end of their training, they did not feel comfortable performing more complex cases. So if we're not training in fellowship as much, then in order to gain robotic exposure and training, we do it in practice. And so some of the people in this room have explained how to do these approaches and incorporate robotics into HPB practice. However, there's been some data in these very studies that show that the learning curve is very steep and timely. The biggest issue with incorporating MIS into pancreas cases is lack of volume and lack of access, which we've talked about a few times today. And so because of that, outside training proctoring is recommended. So what is the learning curve for robotic pancreas surgery? So the Miami International Evidence-Based Guidelines, these esteemed surgeons came together in 2020 to decide what is the learning curve for minimally invasive pancreatic surgeries, including distal pancreatectomy and Whipple's. And from this paper, I quote, MIPD should be limited to experienced surgeons in high volume centers due to the long learning curve and difficulty of the procedure. There was a learning curve of 20 to 40 cases that was quoted. However, there's no data on how long that needs to happen or how many cases per year that you need to have in order to reach that goal. What does the learning curve for robotic HPB cases really look like? So before you reach those 20 to 40 cases to overcome your learning curve, first, surgeons need to be proficient in open HPB surgery. Then they get exposed to the low complex robotic cases. And then they have outside training with dry, wet labs, simulation labs, etc., proctoring of more complex cases. And then they progress to their 20 to 50 cases to overcome their learning curve. So there's actually a lot more that goes into it than just those 20 to 50 cases. This can take many years to achieve, can cause interruptions in your practice to go outside, to have to become proctored, to do sim labs, etc. And a lot of the data suggests that multiple surgeons should be in the procedure, one at the bedside, one at the console, often times alternating resection and dissection. So what was my personal experience? So I did my general surgery residency in Ohio in the States. There were no fellows present at this institution at Mercy Health in Youngstown. And I did log over 20 pancreas cases and 20 major livers with the one HPB surgeon that was at the hospital. I did have a lot of exposure to robotics, over 150 cases by the time I graduated. Because of COVID, I did a year of independent general surgery practice and then went into a HPB fellowship at university hospitals in Case Western. This was 80% open procedures, 20% laparoscopic, and there was essentially no robotic training during this one-year fellowship at Case Western. So after that, I went and did a one-year dedicated robotic HPB surgery fellowship at Atrium Health, Carolinas Medical Center in Charlotte. This was a structured curriculum for robotics with 10 months of clinical robotic training and then 2 months of research. We used dry labs, wet labs, simulation labs, all of the things that we've discussed for the step-up approach for surgeons who are implementing robotics. And then I also had experience in proctoring the residents and other HPB fellows during these labs. So after my training, I became a junior attending at the place where I did my residency, general surgery residency in Youngstown, Ohio. And I joined the one experienced HPB surgeon who was there, and that's where I am today. So my dedicated robotic HPB experience, again, Charlotte, North Carolina. I was mentored by Dr. John Martini, who we all know is a very esteemed robotic HPB surgeon, a high volume of cases. During that time, was able to do 25 robotic Whipples, 24 robotic complex biliary reconstructions, 23 liver resections on the robot. And then we also did other cases, complex duodenal cases, pancreatitis cases, and some microwave ablation. So where am I now? At Mercy Health in Youngstown, Ohio. This is a community hospital, but it's a level 1 trauma center. It has a general surgery program where I trained. It is a high volume HPB center. The one other surgeon that was there prior to me was there for about 8 years, is transplant trained. And so with the two of us together, we do 100 plus HPB cases a year, 50 Whipples, 50 major liver resections, pancreatitis cases, HAI pumps, liver ablations, and obviously robotics. And so we're starting an MIS fellowship in August of this year as well. So after finishing my robotic HPB fellowship, here's my timeline of when I was able to start implementing more complex cases on the robot into my practice. So my first robotic case within the month, the first month of my practice, but within the first 3 months, I did my first robotic Whipple after fellowship. My first major hepatectomy was a year after. And then a little over a year, I was actually able to do my first robotic portal vein reconstruction. And then actually this past week, I did mentor my partner on doing his first robotic Whipple. So my case volumes for the first 18 months in practice, I do significantly more robotic than open cases because that's how I was trained. A lot of complex biliary work, and do a lot of gallbladder surgery as well, but robotic Whipples, liver resections also. So my outcomes for robotic pancreatic duodenectomy after a formal robotic HPB fellowship. So 15 cases in total I've done in the last year and a half. Here's their demographics. What's notable is that our patients in Youngstown, Ohio are generally pretty sick with high ASA scores. They tend not to come to the doctor unless they are very sick, and that's when we end up seeing them. Pathology, all of these cases were done for malignancy, most of which were for pancreatic cancer. So continuing my outcomes, conversion rate was 40%. I converted 4 patients for non-emergently for vascular reconstructions. 1 patient was converted emergently for bleeding, and then another patient for CO2 intolerance. After, however, 9 cases, my conversion rates essentially stopped, and since then I have not converted. Median OR time is 450 minutes, blood loss 300 mLs, length of stay 7.5 days. And here's our readmission rates. I haven't had any leaks, biochemical or otherwise, no in-hospital mortality, and here's our complication rates. And R0 resection has been 100%. This is my median lymph node yield on the robots, and had 4 patients who had preoperative chemotherapy. And again, the 1 robotic vascular reconstruction. So what did I get out of a dedicated robotic HPB fellowship? So I had extended training from fellowship. I had my mentor who was there with me every case of a robotic Whipple or robotic major hepatectomy, who was able to train me for an entire year. And I was able to have somebody there that gave me more confidence to do the procedures more effectively. That mentorship is important. I feel like robotic surgeons who get proctored, yes, they do have mentorship, but when you have it for a longer period of time and that person is in the room with you, it's a different, completely different experience. So it did provide me with a lot more confidence, and I felt confident to do the complex cases straight out of my fellowship. That did provide some marketability, but also I did not need to, leave my practice in order to do any outside proctoring or simulation, wet labs, dry labs, things of that nature. So in summary, the majority of fellows are essentially unsatisfied with their current robotic training, at least in North America. The learning curve for complex HPB cases is very steep, it's very long, and a formal robotic HPB fellowship may provide benefits of improving your comfort level with complex cases when you're finished with fellowship, shortening your learning curve, and minimizing disruptions in practice. And that's all I have. Thank you.